Okay, well, it's 1 o'clock, and thank you all for joining us for today's CME lecture on trauma. Just a couple housekeeping details I'd like to mention. The first is it looks like everyone's muted for the most part, and I appreciate that. If you can just go, if you haven't done so already, go ahead and mute yourself so we don't get any background noise. And then, of course, if you have any questions, feel free to unmute and ask them as we go. Certainly happy to answer questions at the end, or if things come up real time during the course of the lecture, I'm happy to answer those as well. So again, welcome. As far as CME credit is concerned, the activity is worth 1.5 hours of CME credit. And so if you'd like to get credit, we'll go ahead and be sending out an email to everyone with a short survey. And if you can go ahead and fill that survey out at the end of the lecture, that's the way you get your CME credit. So please don't forget to fill your survey out, and that way we can get good feedback, and you can also get credit for attending today. Okay. Okay, so I'll go ahead and get started. Again, thank you all for being here. You know, we hope to someday be able to do these things in person, but for the time being, we'll continue to do these remotely, and hopefully all of our technical aspects go through without a hitch. If there's any problems hearing me or any other visual issues during the course of the presentation, again, feel free to unmute, let me know. Nothing worse than giving an entire CME lecture only to find that no one could hear you. So hopefully everyone can hear me okay, and let me know if there's any glitches along the way. I'm going to go ahead and share my screen here. So hopefully what you're seeing is the title screen to the trauma lecture activity. So today's activity, of course, deals with trauma case studies, and I went ahead and put a few examples of trauma that I witnessed in my childhood, which was in the tune of various cartoon characters obliterating each other. And then as I became an EMS provider, I found that that was pretty closely a mirror of reality. So, you know, why do we need to talk about trauma? Well, I'd like to start off by introducing you to a species of creature on the planet called Homo sapiens. They're pretty smart. You'll see them all over the place. So all you have to do is look around. They have opposable thumbs, which enables them to do some pretty cool things. But they're a little prone to injuring themselves. They don't always make the best decisions. And so from time to time, they'll fall or sustain some other trauma related to activities that they're engaged in. Sometimes there's things that could be done differently to prevent the traumatic injury in the first place. And sometimes we're pretty good about that, but other times we forget. And so we have a tendency to, you know, get electrocuted from time to time. Sometimes we just plain old blow up, and that can be pretty catastrophic. Or in other situations, we may just, you know, not realize some of the dangers that we're incurring with certain activities. We do try to think about safety, you know, and prevent traumatic injuries when at all possible. So that's, I think, a really good first step, but it's hard to prevent everything. And, you know, I think we're making strides, but we still probably have a long way to go before we're in a situation in which we're completely free of trauma. And until that happens, I think a few rules for the road are in effect. One is that to remember that all bleeding stops eventually. And so whether it's at the scene or at the hospital or thanks to the services of EMS, hopefully, there is an end to the traumatic injury. And so our job is to get the patient from the point of injury to definitive care and to try to prevent them from getting worse along the way. So I'll go ahead and start out with a series of case studies, and we're just going to kind of walk through a few cases that involve traumatic injuries and try to pick up a few lessons learned along the way. So the first case that we'll talk about is a 16-year-old male, status post-assault, involved in a fight. Here comes the EMS crew. And what they encounter is that they have the 16-year-old male. He's been in a fight, an altercation with another teenager, and he sustained an injury to his nose as well as pain to his left arm. On HPI, we find the patient reports pain to the bridge of his nose and left arm pain after a fight with another kid. Pretty straightforward. No loss of consciousness is reported. He does feel somewhat anxious, and we learned that he has a history of asthma. So here's a photo of the patient. You can see that there's a very mild deviation to his nose, and he also has some ecchymosis to his left forearm and left wrist, which is probably the source of his left arm pain. And so that's your physical exam findings. We have a few vital signs for you. His blood pressure looks pretty reasonable. He's a little tachycardic, but he was just involved in a fight. And otherwise, the rest of his vitals look pretty decent. So what do? We package the patient and begin transport to the closest facility. During transport, about 5 minutes later, the patient seems to be more anxious than he was when we first picked him up. He states that he feels like he can't breathe. So we repeat his vital signs. His blood pressure remains fairly decent. He's still tachycardic, actually a little worse in his tachycardia than when we first picked him up. And he's become a bit tachypnic as well. But otherwise, his pulse ox seems reasonable. We do repeat our physical exam as well. He does not have any wheezing. His lungs are clear bilaterally, and he does have this history of asthma. So we go ahead and start him on an albuterol nebulized treatment, thinking that maybe it's his asthma that's starting to kick in with all the excitement, the fight, and so forth. A little albuterol can't hurt. 3 minutes later, we're still transporting to the closest facility. Patient he begins hyperventilating. His breathing seems to be getting worse, and he says he feels worse. He appears more anxious, and he actually now at this point he appears short of breath, objectively short of breath. We repeat our pulmonary exam. The patient continues to have clear lung sounds bilaterally. And we repeat our vital signs, and you can see that the patient's blood pressure is starting to get a bit soft, 102/96, and his heart rate continues to climb. He's now more tachypnic, and he's starting to become hypoxic. Whether this is all due to hyperventilation or some other cause is not yet clear. 2 minutes later, the patient now appears pale and lethargic. His blood pressure continues to drop. He's become significantly more tachycardic, more tachypnic, more hypoxic. So medics make the good decision to reroute to the closest trauma center. They start the patient on a non-rebreather for his hypoxia and his tachypnea, and they cut off all his clothes. We kind of forgot to do that when we first loaded the patient into the rig. He seemed like he had isolated injuries. And so we expose the patient, and this is what we find when we expose the patient: a pretty normal appearing anterior and posterior thorax, and his extremities, other than what I showed you with his left forearm injuries, his extremities also seem to be normal. His head just shows the nasal injury and no other big lacerations or hematomas. So Hard to know what's going on here. He looks bad. He looks now pale, lethargic, ill. And 2 minutes later, the patient becomes unresponsive, apneic, and pulseless. CPR is initiated and bag valve mask ventilations are initiated, and the patient undergoes bilateral needle thoracostomies. The paramedic unit arrives at the hospital 5 minutes later. At the hospital, the patient is intubated, CPR is continued, and they do a head-to-toe exam and discover a small puncture wound to the left axilla. There it is right there. The trauma surgeon performs a bedside thoracotomy, opens the chest to find minimal blood in the chest cavity. The aorta is cross-clamped, and the pericardium around the heart is opened to reveal a large amount of blood within the pericardial sac. There's a puncture wound noted to the left ventricle. Here's the wound. And this is pretty much what we do see when we open the chest in the emergency department. You can see the lung, the left lung, and the heart, and indeed the patient has some puncture wounds to the ventricle of the heart. So what happened here is it looks like the patient sustained an injury to his heart itself from a puncture wound through the left axilla into the heart. And with that, he bled out through the wound in his heart into the pericardial sac, and blood accumulated between the heart and the sac that wraps around the heart, which is of course the pericardium. So what do we get with that? You get sort of back pressure on venous return to the heart, because as you apply more and more pressure surrounding the heart, it's harder for the right atrium to fill, and so you get a back pressure of blood through the venous system, and that will give you jugular venous distension. Both the internal and external jugular veins will become distended. You also have kind of the squeezing of the heart itself, so the heart can't expand, it can't fill with blood properly, and so you have decreased cardiac output, because as you recall, cardiac output is a function of stroke volume and heart rate. And if you can't fill the heart, then you can't squeeze an adequate amount of blood out of the heart either, which decreases your stroke volume. And it actually starts to make the systolic and diastolic numbers of your blood pressure come closer and closer together. So that difference between the systolic and diastolic blood pressure is called the pulse pressure. And so with this situation where you have pericardial tamponade, you end up with a narrowing pulse pressure. So the difference between systolic and diastolic comes closer and closer together. And with all of that, you also get, because you have blood around the heart, you're sort of listening to the heart through fluid. And so the heart sounds tend to sound muffled. And so you have this triad of jugular venous distension, decreased cardiac output or hypotension, and muffled heart tones, which is called Beck's triad, as you recall. And again, you can think of it as the 3 Ds: distant or muffled heart sounds, distended neck veins or jugular venous distension, and decreased arterial blood pressure or hypotension. And that is indicative of cardiac tamponade. You may on EKG also see this phenomenon called electrical alternans. And what happens there is the heart is sort of swinging back and forth within this fluid-filled sac. And the heart doesn't normally swing that way because it's not normally surrounded by a significant amount of fluid. And so you'll see a change in the amplitude of the QRS complexes as the heart swings back and forth. And that's called electrical alternans. That's indicative of fluid within the pericardium. So the treatment is to get the fluid out, to get the blood out of the pericardium. You can do that in a couple of different ways. You can take a needle if the chest is closed You can insert the needle below the xiphoid process and sort of aim toward the left shoulder or left clavicle and upward, and advance the needle until you get blood return and evacuate blood through the needle. You can also open the patient's chest, and you can do a pericardial window and evacuate blood surgically. So those are basically the two treatments for cardiac tamponade associated with heart injury. Of course, if the patient has a laceration to the ventricle, that needs to be repaired. Otherwise, you can evacuate all the blood you want, but you're going to continue to fill the pericardium, and the patient will eventually exsanguinate. So I think the lesson here is kind of a reminder about Beck's triad, but also a reminder that trauma patients can be unreliable. You can't always trust the history. And so in this case, the patient was mostly focused on his nose and his forearm, which are the things that hurt him when we first got there. And, he forgot to tell us that he may have been, or maybe he didn't even realize that he had been stabbed during the course of this altercation. Another lesson learned here is that you can't treat it if you don't know about it. So when I was doing my trauma rotation in med school, the surgeon that was the trauma surgeon at the time, he liked to say the eyes cannot see what the mind does not know. And what that means is that you can't make a diagnosis if you don't think of the possibility of the diagnosis first. So in this case, the patient's lung sounds continued to be clear, but he kept looking worse and worse. And so what are we missing here? So you start thinking about, could he have sustained some kind of like finite puncture wound? Could he have cardiac tamponade? Could he have a bowel injury? You have to think about the diagnosis before you can find it oftentimes. It's really important to expose the patient, right? So again, we thought we did a pretty good job exposing the patient. We saw the whole front part of his torso, his back, everything looked fine, but we forgot to check his axilla, and that's where the injury was. It's important to do a head-to-toe physical exam, right? Trauma patients, I think it's very easy to get lulled into complacency. Oftentimes their injury is obvious, and so we start focusing on that right away, and we kind of forget to do that head-to-toe exam. It's amazing what you find when you actually do a head-to-toe exam. And then lastly, if your patient's getting worse, remember to repeat your exam. You may have missed something, and get the patient to the trauma center. Sometimes we don't know what the traumatic injury is. All we know is that the patient is worse, and that's enough to bring him to the trauma center. Okay, so that was case one. Let's talk about the next case, which is a 22-year-old female who sustains a wakeboarding injury. So wakeboarding injury that happens on the water. And when we have a water rescue, the best services to provide are Baywatch and the men and women that patrol our beaches. In this case, we have a dual response from David Hasselhoff and The Rock and the entire crew. And also, thanks to mutual aid, Miami Beach Fire and Rescue happened to be in the area, and they were able to help out as well. So that's really helpful here, getting all of our resources on the scene. And in this case, what we find is that we have this 22-year-old female who was wakeboarding, and she sustained an injury to her left knee. On HPI, the patient again says she was wakeboarding, she hit a wave, and she felt a sudden pain in her left knee. She felt like her knee kind of popped out and popped back in again. Her pain was fairly severe, and she really doesn't want you to get near it at all. She just has a history of depression, no other reported past medical conditions. So here's her exam. You can see that she's guarding her left knee. Her left knee is swollen. She's got an effusion there. She's very tender. Again, she doesn't really want you manipulating the knee much, but she's pretty uncomfortable. Any attempt at movement causes pain. As far as the lower extremity distal to the knee, not a whole lot to find, no significant lower extremity edema, and she has a normal tib fib and ankle exam. So we load her up, move her to the ambulance, and take her to the hospital. When the patient gets to the hospital, this is what we find. They do x-rays, and that's an x-ray of her knee. We don't see any significant fractures, but there is a joint effusion noted, and that makes sense if she sprained her left knee. We actually x-ray the bone above and the bones below the joint, so we get an x-ray of her femur and her left tib fib, and there's no fractures there as well. So the diagnosis is left knee sprain, possible cartilaginous injury. And the treatment for that is a knee immobilizer. We place her in a knee immobilizer in the ER. We fit her for crutches, and we give her a prescription for some pain medication and instructions for rest, ice, compression, and elevation. We tell her to follow up with orthopedic surgery in 1 to 2 weeks. Perfect. But because this is a trauma lecture where bad things happen to good people, in this particular case, the patient ends up returning to the emergency department the following day. And when she returns, she notes that she has worsening pain and numbness now to her left lower leg and foot. Here's her exam. You'll notice that she's developed some areas of necrosis to the toes of her left foot. She has now swelling to her left foot as well. Some of the skin, overlying skin, looks kind of brawny. On physical exam, you note that the patient has a cold left foot. She has no sensation to light touch when you do a sensory exam, and you're unable to palpate pulses to the dorsalis pedis and posterior tibialis area. So as the ED physician, if I see this patient in the emergency department, I know that I need help, and I need to contact the people that are going to help me the most. And so the first call we always make, from the emergency department is to our malpractice carrier. We make sure we get ourselves covered right away and take care of that aspect. And then, of course, we start thinking about patient care. And in this case, I would call the vascular surgeon. And I call the vascular surgeon, and the vascular surgeon says to me, get a CT angiogram of the left lower extremity. I'm on my way in. And for the vascular surgeon to say he's on his way in without me prodding means that this is probably something really bad. And so I'm going to get a CT angiogram of the left lower extremity. And when I do, what I find is that the patient sustained has extensive intraarterial thrombus within the popliteal artery. She has a lack of blood flow to the distal extremity, and there are signs of tissue ischemia. So what happens to this patient? She goes directly to the operating room, taken there by the vascular surgeon, and it's noted in the OR that she has extensive ischemic injury noted to the muscles and soft tissue of the distal lower extremity. And she ends up undergoing popliteal artery repair with saphenous vein graft. She gets a thrombectomy to remove the blood clots. And because she's got ongoing soft tissue swelling and now developing compartment syndrome, she ends up getting fasciotomies as well. She gets admitted to the hospital. Things start to kind of evolve from there. Unfortunately, they kind of go from bad to worse. She has progressive lower extremity necrosis of her lower leg. Here's a picture of her lower leg. She ends up, unfortunately, sadly, going back to the OR for an above knee amputation because of just extensive necrosis to that lower leg. She develops all of the potential side effects and problems with extended hospitalization, multiple surgeries, She developed shortness of breath on hospital day number 8. We end up getting a CT angiogram of her chest, and she's got a large PE. She started on IV heparin, and she develops just badness, ARDS, sepsis, DIC, you name it. And in some cases, these patients will expire, but this patient actually catches a break, and she does recover from all of those complications, and she's discharged to the skilled nursing facility on hospital day number 42. So she's in the hospital for about a month and a half.
Carolina.
So what do we learn from this?
Over here?
We learned a couple of things. One is traumatic knee injury can be bad.
Okay.
If you have a situation in which you have traumatic knee injury, severe pain, and diminished distal pulses or sensory deficits, that's concerning for vascular injury.
Okay. What is it?
Knee dislocations
The
are commonly associated with vascular and nerve injury.
then so we have
And I just put a shout out to folks listening. I think somebody is off of mute right now. If you can just mute, because I think we're getting a little cross traffic from you. Vascular injuries, if missed, often lead to limb loss. So here's a study taking a look at vascular and nerve injuries after knee dislocation. And they took a look at 862 patients with knee dislocations. 171 of those patients sustained a vascular injury. So 20%, 1 in 5 patients with spontaneous knee dislocations from traumatic injuries had a vascular injury. 25% of those patients sustained a nerve injury, and 80% of vascular injuries underwent repair. So if you sustain a knee dislocation and you end up with a vascular injury, the vast majority of those patients will have to go to the OR emergently for vascular repair. Unfortunately, 12% of these injuries resulted in amputations. So if you do a little math here, what that means is for all comers, just by traumatically dislocating your knee, about 16% of those patients who traumatically dislocate their knee will require vascular surgery, and 2.5% of those patients will ultimately end up with an amputation, a surgical amputation to the injured extremity just by dislocating their knee. It's a huge number. How do people dislocate their knee? They do it all kinds of ways. You can have a rotatory dislocation. You can have medial or lateral dislocations. The knee can be dislocated posteriorly, and you can see there how the popliteal artery can be injured in the process. And also you can have an anterior dislocation. Anytime you're moving the tibia out of position and off of the femoral condyles. Notice how the vessels and the nerves run very close to that joint. And so when you have this traumatic injury to the joint, the vessel and nerve are commonly injured. Up to about 50% of knee dislocations spontaneously reduce prior to the arrival in the emergency department. I think this is probably what happened to our patient who sustained her wakeboarding injury. Is she dislocated and then she spontaneously reduced prior to EMS arrival. So the problem with this is that these patients don't come in with a sign on their chest saying, I've dislocated my knee. They just come in with a knee injury. And it may be EMS that gets that initial report that the patient felt like her knee popped out and popped back in again. That's really important to relay to the emergency department physician and nurses, because that report alone can raise suspicion for traumatic knee dislocation rather than just a routine sprain. These are entirely different injuries, and they have entirely different morbidity and mortality. So it's important to get that history, and EMS may be the only people that get that history right off the bat. A lot of times traumatic dislocations of the knee can be associated with fractures, and that can be distracting because you have a fracture, and we focus on that as a source of the patient's pain. And so it can be very easy to not realize that the patient also sustained a traumatic dislocation, particularly if they're already reduced by the time they get to the ED, and we forget to do a CT angiogram. Any kind of varus or valgus instability of the knee in full extension is suggestive of a grossly unstable dislocation. Here's sort of a photo showing, how you would do a varus or valgus stress test with the knee in full extension at the top there. And sometimes it's also done with the knee in slight flexion. But what you're looking for is significant difference between one knee versus the other. Now, oftentimes these patients are very uncomfortable, and they may not allow you to get this close to their knee. But if you do find this finding in the field, it's really important to relay that to the emergency department team. Coexistent peroneal nerve injury occurs in 25 to 35% of patients. And peroneal nerve injury most commonly manifests as decreased sensation to the first web space with impaired dorsiflexion of the foot. So the peroneal nerve has a couple of different branches to it. And you can see the cutaneous sensory distribution there in the picture to the left. And what I want to focus on here is that if you note at the bottom between the first and second toes, that first web space is the cutaneous distribution for the deep peroneal nerve. And that's the most common finding. That may be the only decreased sensation finding that you find on a patient with a traumatic knee dislocation. So it's important to, again, do a full exam, get as much information as possible. And if you do happen to notice that, bring it up to the ED staff, bring up the possibility of knee dislocation. And that can be helpful in just triggering them to get the right tests. Again, red flags for vascular injury, pain out of proportion to exam. Anytime a patient has much more pain than you would expect from the injury that they sustained, you probably missed something. That's a red flag. Diminished or absent pulses are certainly a red flag for vascular injury, and expanding or pulsatile hematomas, palpable thrills, if you hear bruit, and any of these red flags warrant vascular surgery consultation and repair if there's a vascular injury. Why is it so important to get the vascular surgeon on board quickly? Well, because time is critical. Vascular repair delayed more than 8 hours after injury carries an amputation rate of greater than 80%. On the flip side, if we're able to get a vascular surgeon on board quickly and get the patient to the operating room, vascular repair within the 8-hour mark from the time of injury yields a limb salvage rate of 80%. So in these situations, time is really critical. And the biggest enemy of that time to OR is failure to diagnose. And the biggest enemy of failure to diagnose is the fact that these knee dislocations oftentimes relocate themselves, reduce themselves spontaneously prior to arrival, and that we just don't think about the possibility. So really, in this case, the diagnosis is in the history. All right. So I'm not saying don't go wakeboarding or water skiing. I'm just saying be careful. So let's go to our next case, which is a 25-year-old male with a hand injury. He's using a circular saw and had a slight mishap with the saw. So a little bit of background on traumatic amputations. Naturally, finger amputations are very common. We see about 100,000 finger amputations per year in the United States. It's just a real common injury, unfortunately. And about 30% of these amputations are suitable for replantation, about a third. In terms of terminology, a few things to kind of be aware of. When we talk about amputations, we're talking about the injured part is no longer attached to the patient. that seems kind of obvious, but terminology is actually important here because patients can have partial amputations, in which case the injured part remains partially attached to the patient, right? And when something is partially attached or mostly attached, well, your friend here is mostly dead, which also means that mostly dead is also slightly alive. So there's a chance, there's a better chance for getting that finger reattached. And actually in a situation where you have a partial amputation, we're not really talking about replantation, we're talking about revascularization. We're talking about getting vascular supply back to that partially amputated portion of the finger. As you may guess, there is some gender disparity in patients who end up lopping off their fingers and other parts of their bodies. Men tend to be a little bit better at this than women. We like to, do dumb things, and we do them more frequently. So we do have that going for us. What can be replanted? Well, lots of things can be replanted. So fingers, toes, hands, feet, ears, penis, nose, basically any appendage that gets amputated has a chance of being replanted. It just really depends on how it's packaged, how long it's been since the injury, and other patient focused factors such as comorbidities. Proximal extremity amputations can sometimes be replanted. It's much more difficult. It's much more unlikely that that's going to take. And the important thing here is to make sure that the patient is stable enough to, undergo a replantation. These injuries oftentimes involve significant bleeding, and we want to make sure that the patient is stable from a trauma standpoint first before we focus on replantation. And the worst thing to do would be to get a patient with a amputated body part to the specialty center for replantation, and the patient dies en route. We want to make sure that we save the patient's life before we go after the limb replantation, especially knowing that it's proximal traumatic injuries are much less likely to be successfully replanted. So again, always prioritize life over limb. And we mentioned this already, fingers are the most common traumatically amputated body part. So if you forget or just want to see it in writing, Monterey County EMS Agency has an app that you can download for your mobile device. And we also have this on our website as well. Under policies and procedures, you can go under that and you can click on field trauma triage criteria, and that'll take you to this page, which is field trauma triage algorithm for adults. And we also have one for pediatrics. And what this will tell you here is that if you look at the top 3 criteria for step 1, I'll blow this up a bit. So patients with altered mental status, patients that are hypotensive, or patients that are not breathing appropriately or need ventilatory support, those are step 1 patients. Also for step 2 patients, here's 2 things involving amputations, which is crushed, degloved, mangled, or pulseless extremities, or amputation proximal to the wrist or ankle. Any of these patients, the appropriate disposition is to bring them to the trauma center, because again, we're prioritizing life over limb. And these patients are at higher risk of dying from their injuries with prolonged transportation. What are the indications for replantation? Well, there's a bunch. Amputations to the thumb or multiple digits might be an indication for replantation. Amputation of a digit in a child. Amputation of a digit in zone 1 usually is a good candidate for replantation. Zone 2 might be a candidate. And once you get into zones 3, 4, and 5 of the hand, it's much more difficult to have a successful replantation. And so that's more rare. And I'll talk about the zones shortly. Some contraindications for replantation: prolonged ischemia of the amputated body part. The injury occurred 12 hours ago, 24 hours ago. That's not going to take. Segmental damage to the amputated body part. In other words, if you're talking about one finger, but that finger got severed in two different locations segmentally, again, that's going to be tough to get that reattached successfully. And diffuse crush or severe avulsion injuries would be a contraindication for replantation. Also, fingertips, end of fingertips that get amputated distal to the DIP joint. I'll review with you what the DIP joint is, but we're talking about like just the very end of the fingertip that gets amputated. We generally don't send those to a replantation center. We generally repair those in the emergency department. So a brief review of bones of the hands and fingers. Here's a diagram for you detailing the different bones in the hand, wrist, and distal forearm. And I remember this even still from medical school. People think that medical school is complicated and mostly, we do a lot of biochemistry and a lot of very detailed things. But what it mostly consisted of, from my recollection, is sitting around the classroom and singing that song. Hand bone is connected to the wrist bone, and the wrist bone is connected to the forearm bone, and they just make you do that over and over and over again for 4 years. And by the end of the 4 years, generally you remember a few things. And so anyway, that's really the key to successful completion of medical school: a good singing voice and stamina. In this situation, I am diagramming the DIP and PIP joint. DIP stands for distal interphalangeal joint. And the PIP would be the proximal interphalangeal joint. Those are those locations there, basically your knuckles on your finger. And then you also have the metacarpal phalangeal joint, which is your more proximal knuckle. And so when we're talking about those joints, it's good to kind of remember what these are. So there are different zones of the hand and fingers when we're talking about amputations. And this, again, comes down to nomenclature when you're describing an amputation in the field and you're reporting it to the trauma center, or you're reporting it to the replantation center. Knowing what you're talking about really helps, and it gives them a better picture of what's going on. So there's zones 1 through 5. Notice that we start distal and work our way more proximal. In the picture of the bone on the right upper aspect of the diagram here, I'll just point out that there's 2 things labeled here, which is FDP and FDS, and what that stands for is tendons. These are 2 different tendons to the finger, and FDP stands for flexor digitorum profundus, and FDS stands for flexor digitorum superficialis. And those are long, complicated names, but they actually are clinically relevant, and I'll show you why. But in this picture, just note that the FDS, or the superficialis tendon, branches, and it sort of bifurcates and inserts on both sides of the finger, but it inserts in that middle phalangeal bone. It doesn't go all the way to the end, whereas the FDP, or the profundus tendon, it goes all the way down to the very end, the distal phalangeal bone, and inserts there. And that makes a difference in terms of ease of replantation, and why zone 1 is easier to replant than zone 2, and so forth. So here's another picture of those 2 tendons. And again, this is just showing that the profundus goes all the way to the distalmost phalangeal bone, whereas the superficialis stops at the middle phalangeal bone. And you'll also notice that the superficialis kind of has more bifurcations, it's more complicated. And so when patients end up sustaining an amputation in zone 1, there's less to fix. And so, it's an easier replantation from the standpoint of tendon injuries and functionality than a patient who sustains a tendon injury in zone 2. There's just more stuff as you get more proximal, which is why it becomes more and more difficult for the hand surgeons to replant injuries as they get more and more proximal. And when you get into the MP joint area, you have, again, these complex pulleys. You've got lots of nerves, you've got lots of muscles and bones. And again, it just gets increasingly complex. And at the end, you have, at the wrist, you have your flexor retinaculum, which is basically your carpal ligament, your transverse carpal ligament, or people get carpal tunnel syndrome. And that kind of defines the end of zone 4 and zone 5. So again, here's your zones of the hand and fingers. So pre-hospital care for amputation injuries, as always, we want to assess and stabilize the patient. We want to remember that we want to prioritize life over limb. We want to calm and reassure the patient and ourselves. These can be pretty psychologically traumatic for everyone. And so we just want to take a moment to breathe and reassure the patient and ourselves that it's going to be okay. Find all the injuries. So don't get distracted by the most obvious injury. In horrendous fractures or amputations, it's really easy to get tunnel vision on the one most obvious, most gruesome injury and miss other injuries that the patient sustained. So make sure you do a thorough exam, because the most commonly missed injury in trauma is the second injury. And the second missed injury might be more life-threatening than the amputation. So make sure that you're doing a good exam. Don't get tunnel vision. Do a good head-to-toe exam and don't miss that other second injury that could make a big difference in patient outcome. You guys are very good at treating hemorrhagic shock and transporting patients quickly and effectively to the emergency department or trauma center. You know how to stop the bleed. IV access can be helpful. Initiate IV fluids if the patient's hypotensive. And splint partial amputations in a position of extension. As far as packaging, remember to include the amputated body part in your transport to the emergency department or trauma center. So collect and preserve all amputated body parts. Don't assume an amputated part can't be used. Parts not suitable for replantation can provide things like tendons or bones or other helpful things when we're attempting to reattach amputated appendages. And it's very important to cool the amputated body part. So cooling markedly prolongs the window of opportunity for replantation. The rule of thumb is 1 hour of warm ischemia, in other words, not cooling the appendage, is equivalent to 6 hours of cold ischemia. So you have 6 times the amount of time to replant the amputated body part if it's packaged correctly. So one of the most important things you can do in the field is make sure you bring the amputated body part with the patient and package it appropriately. How do you package an amputated body part? Well, you wrap it in saline-soaked gauze and then in a towel if you have one. And place those items in a dry plastic bag and then place the bag on ice or inside a second plastic bag filled with ice and water. So you really want to cool that amputated body part. Transport, I'll say this for the 5th or 6th time, life over limb. Hypotensive patients should go to the trauma center. Patients who sustain crushed or degloved or mangled or have pulseless extremities should go to the trauma center. Those patients are not good candidates for replantation. Patients with amputations to the proximal to the wrist or ankle should also go to the trauma center per Monterey County protocol. When in doubt about the appropriate destination, contact the trauma center base hospital physician to get guidance. If the patient meets criteria to go directly to the replantation center, these are the replantation centers within California. There are some others, but these are the big ones, according to the American Society of Surgery of the Hand. Stanford, the Bunkie Clinic in San Francisco, LA County, and San Diego all have specialized replantation centers. I did call around some other hospitals, and there are other hospitals that do this, but they're not always prepared for EMS to bring them these patients. So it kind of depends on who's on call, what time of day it is, bed availability, all that kind of stuff. But these centers should accept your patients. So that brings us to case 4, which is a 4-year-old male pulled from a burning building. On assessment, we assess airway, breathing, circulation, disability, and exposure. We find that the child is unconscious with shallow breathing and stridor. The patient has pulses. He has partial thickness burns to the right side of his face, to the right side of his neck, right arm, and torso. So significant burn injuries. He has soot in his mouth. The treatment, we remove the soot as much as possible and suction the patient's oropharynx. We assist in ventilations with supplemental oxygen. We assess whether the ventilations are adequate. If necessary, we may put some sort of airway adjunct or supraglottic airway in place. We try to establish access via IV or IO. So we do those things, and now let's try to think about what is the next most appropriate step. So we have some choices here. The next most appropriate step would be to A, administer IV fluids and morphine for pain control. B, calculate the % body surface area burned using the rule of 9s. C, transport the patient to the closest emergency department. D, transport the patient to the closest burn center. E, contact the base hospital physician for instructions regarding the most appropriate destination. So those are your choices. Let's just kind of review what we have here to try to decide what the best answer is. So we have a child who's unconscious with shallow breathing and stridor. And stridor is a sign of airway compromise. The child does have pulses. He has partial thickness burns to the right side of his face, neck, right arm, and torso. And given the fact that he has facial burns, that may be indicative of an inhalation injury. He also has soot in his mouth, which is pretty indicative of an airway burn or airway exposure injury. Again, airway, airway, airway. So you see airway a whole bunch of times in this slide. So now, kind of remembering all that, what's the most appropriate destination for this patient? The most appropriate destination is the closest emergency department. Why the closest emergency department as opposed to the burn center? Because this patient has an unstable airway. That will kill him far faster than his burn injuries. He will need burn care for sure. But again, we don't want to deliver a dead patient to the burn center when the burn center is a much further distance from the closest appropriate hospital. So get this patient to an emergency department for airway stabilization, and then they can transport him to the burn center, but get the patient stabilized first. What if this was an adult and not a pediatric patient? Here's your choices. Same choices as before. Again, it's the same principle. If this patient has stridor, airway compromise, soot in his mouth, he's unconscious, he has an unstable airway, this patient needs to go to the closest emergency department to save his life, to take the airway and secure the airway. And then once the patient has a secure airway, we can do all kinds of things. You know, we can do the roll of nines, we can give them fluids, we can contact the burn center, we can, you know, give him pain medication. But if the patient does not have a stable airway, none of those things are going to help him as much as stabilizing his airway. Same principle if this is a trauma patient, either adult or peds. Here's your choices, same choices as before. If this is a patient who has a truly unstable airway, then this patient should go to the closest emergency department. Now, if this patient has a stable airway, or if this patient has a bunch of traumatic injuries that are placing him at high risk of death, and his airway is good enough to make it to the trauma center is fairly close, then transporting this patient to the trauma center is the appropriate choice. But notice that transporting the patient to the burn center is not the appropriate choice for either of these patients. Because again, you have to prioritize the things that are going to kill the patient first, and then address the burns later. Something that I think is important to just remember about burn centers is they do great work, and I'm very thankful that we have them. But burn centers are not emergency departments. When you transport a patient to the burn center, quote unquote burn center, what you're really doing is transporting the patient to the emergency department that's associated with the burn center. Valley Medical Center has a burn center. And when you transport the patient to the burn center, you're transporting them to Valley Medical Center Emergency Department. The first team that sees that patient is not the burn team. They may be in the background, they may be ready to assist, but that patient, if it's traumatic injuries, that patient's being seen by the trauma team. If it's non-traumatic and it's airway related, that patient's being seen by the emergency department team. But either way, you're not rushing them to the burn doctor. You're rushing them to an emergency department or a trauma center, which is just the same as an emergency department or trauma center down here in Monterey County. So I think, again, it's important to keep that in mind and make sure that we save the patient's life first and worry about the burn second. All right, that brings us to case number 5, which is shots fired, which no one really ever wants to hear over the radio, but unfortunately, we live in a world where that happens. And so this is what the scene looks like at the time of the initial call out. Pretty chaotic. So what I'd like to talk about is a white paper that was put out by the Assistant Secretary for Preparedness and Response, as well as the Healthcare Emergency Preparedness Information Gateway, or TRACY, which talked about mass casualty trauma triage. And it was based on a meeting that they had where they reviewed Mci triage, what we have been doing, what we could be doing, what's in the future, and also how it relates to this new paradigm of MCI, which is the multiple high velocity injuries involved in mass shootings and other situations in which the mechanism of injury is profound and the number of patients can be overwhelming. So they had a lot of good points in this paper. I highly recommend reading it from start to finish. It's well worth the time. And I've taken quotes from this document and put them here in this lecture to kind of try to highlight some of the points that they were trying to make. And one point is that as a nation, we've got a lot of trailers with backboards and colored tape out there, and that's not what the focus of mass casualty response is about anymore. So let's talk a little bit about, how things used to go and how we envision things going when we talk about MCI and traditional triage. So EMS providers arrive at the scene of an MCI and initiate triage, moving green patients to a single area and grouping red and yellow patients using triage tape and tags. Patients are then transported to local hospitals according to their priority group in an orderly fashion. Tagged patients arrive at the hospital and are assessed and treated according to their priority. That sounds like it makes a lot of sense until you try to apply that strategy to this, where the scene is still unsecure, where you've just got a mass of people running in all directions, some of them getting trampled by others, and patients physically carrying other patients away from the scene on foot, heading in all directions. It's very hard to apply that strategy to this kind of an incident. So, especially in mass violence incidents involving time-critical injuries and ongoing threats, traditional triage may not be feasible and can result in mistriage and outcome-altering delays in care. So what does traditional MCI, when does traditional MCI triage fail? Well, it tends to fail in situations in which the scene is still very dangerous and the scene is also dynamic and changing rapidly. It tends to fail when the number of patients far exceeds our usual resources. We just don't have the resources to do traditional MCI triage for the number of patients we have. When the threat or perceived threat causes patients to flee the scene. So it's hard to triage patients when they're not even there. They've run away. When the mechanisms of injury cause rapid deteriorations in patient stability. So if you get shot in your torso by a high caliber weapon, you may actually look okay when EMS first assesses you, and you may be dead 5 minutes later. So in situations like this, you can have rapid changes in the patient's stability. And so you triage that patient as a yellow, and 5 minutes later, they've expired. It's also difficult when the primary mode of transport is not EMS. Where do patients get to the hospital? They take Uber, if they can get one. They go by personal vehicle, or more likely, they just go by foot. So confounding factors in mass violence incidents include the following. It's unclear when the threat has been neutralized. In the situation of the Las Vegas shooting, it can be very unclear. Is there one shooter? Are there two shooters? Are there explosives that have been set up nearby? And so even when, the scene is quote unquote secure, all that really means is that we think it's secure. And so that's definitely a confounding factor in these situations where we have mass violence incidents. Again, in the first few hours, the scene can't really be considered safe. It can be considered safe enough to enter and attempt rescue. There can be injuries from panic crowd movement that can be fatal or can exceed the injuries from the primary threat itself. Patients oftentimes, as I alluded to, flee the scene and then they call 911 from a different location, making dispatch and EMS response chaotic and confusing. You can imagine if you start out with 500 people and they all run in different directions and then call 911 from their cell phones or from their friend's house, how completely chaotic that is. And traditional triage will not work in that situation. Another confounding factor in mass violence incidents is that patients often go to the closest hospital, which may not be the right hospital, right? It may not have the resources or expertise. It may not be a trauma center. It may not have the staff and the ability to take care of those patients, but they go there anyway because the patients are taking themselves to the hospital. So what are some sort of takeaways from this? This is obviously a huge topic for discussion. It's not something that we're going to hammer out here in a few slides, and it's a topic that would be an undertaking with all of the departments and the county and other surrounding counties. But a few sort of take-home points here, I think, are: one is it's really important to be adaptable. In real-world incidents, EMS personnel actually often do not follow triage protocols that have been outlined by the agency or departmental mandates in mass casualty plans. What happens is that they do the best they can. And as it turns out, that's pretty good, because there's really little to no clinical evidence showing the superiority of any specific triage system over traditional provider assessments. And so your judgment as an EMS provider is as good as the triage system that your department may have in place. And of course, if you have everyone doing things differently, that can lead to chaos. And there's definitely a time and place for traditional triage. But what I'm talking about here are mass violence incidents in which the rules of traditional triage just don't apply. So it's important to use traditional triage when it's appropriate, but it's also important to be adaptable. Another important point here is that triage must occur where the patients are. So in this situation where you have an active shooter, it may be impossible to do triage at the scene. And you may not want to anyway because the scene is not safe. Maybe most of the patients run to the closest hospital, or most of the patients end up in a staging area away from the scene. And so you have to take triage to where the patients are instead of expecting that the patients are going to come to you. It can be at the scene, but more often in these situations, it can be in a staging area, in a hospital, or another location that you have a gymnasium that you have everyone just go to the gymnasium because that's a safe area. Everyone go to the church down the block. Everyone go to the open field, 3 blocks away. So you find an area that's safe and you use that. And in real life, most likely, triage is occurring in all of these areas at the same time. What are the 3 stages of triage? Well, there's primary triage, right? There's triage that's performed during your first encounter with the patient. And the idea of that is that you want to establish initial priority life-saving interventions and you want to decide where that patient's going to go. It can be done by EMS, first responders, or it may be done by hospital personnel. If patients run to the closest hospital, maybe that primary triage is occurring in the parking lot of the hospital and not at the scene. Again, an important part of primary triage is moving living patients away from the unsafe area. Assess for life threats and provide immediate treatment in an area of relative safety. And identify appropriate destination hospitals based on the patient's injuries and stability. So that's primary triage. That's where EMS comes in. And again, that can be done in many different locations. Secondary triage is a reevaluation of your primary triage category. It's essentially performed after additional assessments and interventions have occurred. It's often used at the hospital to prioritize patients who needs to go to the operating room or who needs advanced imaging like CT. And so that oftentimes is not done by EMS, but it could be done by EMS in the field, particularly if the patients at the scene have sustained mechanisms of injury associated with the potential for rapid changes in their condition. We talked about high caliber weapons and blast injury and you know other things that may render patients highly unstable, and they could go from a green to a yellow to a red pretty quickly. And then there's tertiary triage, and this is generally done at the treating facilities. It's performed during ongoing definitive care at the hospital. Basically evaluates whether ongoing resource commitments are sustainable or whether additional resources are necessary. And it's, you know, EMS has a role to play here. As you can imagine, if you're a hospital staff and you get 82 patients from a mass shooting event, you're completely overwhelmed. And the best use of EMS resources may be in the hospital parking lot, assisting with ongoing triage and transfer operations. That may be far more effective than being at the scene. Or maybe some resources are assigned to the hospital and some are assigned to the scene. So there's different ways that you can support the hospital, and it can really make a difference for an overwhelmed hospital who is just completely inundated with trauma patients. So we talked about adaptability being essential. We talked about the fact that triage must occur where the patients are. And we talked about modifying triage categories to fit the incident. So an example here is that the two triage categories that are considered the most important in these mass violence incidents are red and black or dead. And, you know, assigning patients to one of those helps to define those patients who either require no resources or those who require, you know, the most emergent resources, and getting that patient to the trauma facility as quickly as possible. There was a lot of discussion in this paper about distinguishing red from yellow prior to transport, and the fact that that may not be helpful. What do I mean by that? Well, separating red patients from yellow patients with penetrating torso trauma, as I've alluded to, you've got a high number of patients who sustain these injuries. The safety of the scene is questionable at best. And red patients can become yellow patients that can stabilize and be fine, or yellow patients can become red patients very rapidly. And so if you take the time and resources to separate these two into two separate groups, that's at the same time patients in each group are moving from one group to the next because their stability has changed and is not, you know, they're not stable, then you may have really wasted time and resources in separating these patients out. It may be better to just have one big group be the red-yellow group. And then once the patient gets to the hospital and they're doing their secondary triage, they can really determine who needs to go to the operating room and who's okay to wait. A little bit more on modifying triage categories to fit the incident. Under and over triage are both dangerous and can affect patient mortality. So for under triage, in other words, the level that you assign the patient is not high enough to meet their traumatic injuries. So you have delayed treatment and transport of very severe traumatic injuries that may not be appreciated at the scene. And of course, transport to an inappropriate hospital where the patient can't get the definitive care that they need, and all of the increased mortality that can come with that. So it's important not to under triage patients. It's equally important not to over triage patients. So if you assign too many patients to red, then you end up in a situation where you've diverted your resources from those who need it. Some of these patients may be stable and not require all the resources that you're allotting for them, and other patients may be less stable and not have the resources available. And as you can imagine, if every patient is red, you can very quickly overwhelm your trauma center. Another thing that the paper talked about was that triage oftentimes is most effectively performed by an experienced provider. For example, an ER physician, in some cases an ER nurse, someone who has seen hundreds of thousands of trauma patients and can look at a patient and know stable, not stable. And that's a skill set that only comes with seeing tons and tons and tons of trauma. Maybe it's the trauma surgeon who would be the best person to do that. And in situations like that, it may be helpful to move triage to the provider. In other words, again, doing your triage in the hospital parking lot where you have access to an experienced provider, or bringing the provider to the triage area. If you're doing triage in a gymnasium, for example, assigning an emergency physician to go to that area to help with triage, because that can make a big difference on resource utilization. They may be more effective doing that than actually treating injuries in the ER. Emergency dispatch has a big role to play here. Triggers should be identified for automatic assignments of resources to potential MCIs. For example, the EMS work group for this particular paper identified multi-person shootings or MCIs involving at least 10 patients as thresholds for sending an initial response of at least 5 EMS units plus a supervisor. In other words, the call goes out, and rather than try to figure out how many patients you have an automatic assignment for that. And this can be titrated for anywhere from 10 patients to 20 to 50. Some jurisdictions have this dialed in so that there's a different assignment based on each patient number threshold. So this can really be dialed in. It can really help in just getting the units to the scene and then figuring out exactly how many you need as information unfolds. And as we've talked about, a tremendous amount of resources can be wasted responding to active shooter calls that are not secondary active shooter incidents, but result when patients flee the scene and then call from a location of safety. So in terms of emergency dispatch, it's really important to clarify, where were you when you were shot or injured, and are you safe now? Hospitals also have an important role to play here, and hospitals will need to modify their operations to respond to these incidents, establish a system for calling in off-duty staff. Most hospitals have that already, but they may not have that for these types of incidents where they really need all the help that they can get. Again, we talked about the most experienced providers may be best assigned to triage and not treatment. Using rapid patient identifiers like tags, similar to what we have with EMS, should be utilized if possible. And of course, electronic health records are going to fold in a situation like this. They'll just become overwhelmed. And so we shouldn't rely on them during triage and resource utilization. And then, there's EMTALA requirements that require emergency departments to evaluate, treat, and stabilize every patient that arrives in the ED. But in situations where it's a true MCI and you have 100 patients at your door, you may need to suspend EMTALA requirements momentarily. You may need to tell the patient that's there for cough and cold, they need to go someplace else. And that's not something we like to talk about, I think, because EMTALA is drilled into us, so rigorously. But there may be situations in which we need to suspend EMTALA requirements in order to save the most lives. Stable inpatients may need to be discharged pretty quickly or transferred to alternate sites to make beds for incoming patients. And hospitals may need to send patients and staff to alternate locations as well. In some situations, hospitals may need to modify their primary function to suit the scenario. And a good example of this would be, let's say that this was mostly adults that were at this concert, and there were a few children, and there were few or no children involved, hopefully. And the pediatric hospital is within the geographic area. They may need to become the hospital for patients who are triaged as green. Even though they're adults, it may be that, these are physicians, they can treat adults, especially adults with minor injuries. And so the pediatric hospital may have to sort of put pediatrics on the back burner for a moment and help to treat patients who are less severely injured. So hospitals may need to modify their primary functions for these scenarios. So that's a lot, I think, in terms of MCI, things to think about. But I think it's an important topic and something that is worth looking into as these incidents occur more and more frequently. I have one more case to go over, and this is case number 6, and this is a 32-year-old male, status post-MVC. On assessment, the patient was involved in a high-speed MVC, an auto versus tree. He has a GCS of 10. We'll give him a 2 for eye opening, so he opens his eyes to painful stimuli. His best verbal response is a 4. He's confused and he withdraws from painful stimuli, but doesn't localize. So he has a GCS of 10. He has a large scalp laceration with active bleeding. He has a flailed chest. There's an open right forearm and right ankle fracture. He has multiple abrasions and he's not moving his lower extremities. Patient is placed in spinal immobilization and moved to the ambulance. The most important next step is, I'll give you some choices, splint the flailed chest. B, establish IV access and administer IV fluids. C, obtain vital signs. D, transport code 3 to the closest trauma center. E, intubate the patient for airway protection. F, splint the open fractures. G, administer TXA 1 gram and 100 milliliters normal saline over 10 minutes. Or H, call for a helicopter. I'll give you that the patient, this injury occurred in Monterey. So looking at your options here, I think the most appropriate thing to do, I would say would be to transport the patient to the closest trauma center. And I'd like to talk about that a little bit. There's an article from the Journal of Emergency Medical Services that is entitled Pre-Hospital Trauma Management, We Can Do More by Doing Less. I think it's a really good article to take a look at. And I'm going to talk about some of its key points here. There's ways that EMS can have a profound effect on patient mortality when it comes to trauma. And interestingly, maybe soberingly, despite all of our advances in EMS, and there have been many, in pre-hospital trauma care, trauma patients still die from potentially preventable conditions. Many pre-hospital trauma strategies, unfortunately, have not been shown to significantly improve patient morbidity and mortality. Intravenous fluid therapy in the unstable penetrating trauma patient contributes to additional call time and poorer outcomes. And I'm going to go over some studies that show this, but here's a fairly large study from 2016 of 164,500 patients, found that prolonged EMS treatment scene time was directly associated with increased patient mortality. Here's another study from 2014 that found that conducted in urban areas revealed that mortality following penetrating trauma is greater for patients transported by EMS than for those transported by law enforcement or private vehicle. If you're like me, I don't like hearing this stuff because I want to believe that we're so much better than that. But this study found that survival was increased for patients with penetrating trauma if they were not transported by EMS. And so, you know, I don't like to hear that kind of data because I believe in EMS and I know that the skill set that we have out there is far, exceeding certainly the skill set for law enforcement or the general public. And we can do really good things. We can save lives. And I think it's great that we're delivering pre-hospital care to patients at the scene and shepherding them to the local trauma center in an attempt to save their lives. But I think these studies have to, tell us to take a step back for a moment and sort of just think about what is it that we do well for trauma patients and what is it that gets in the way of decreasing their mortality as much as possible. And so when you're looking at a progressive pre-hospital trauma care system, I think we have to sort of recognize where we can help and where maybe we can improve. And so how can we change these numbers? What can we do differently to turn these numbers around as a country and as a county as well? So one is, do not delay transport for pre-hospital IV access. IV access, as anyone who has worked in the field knows, is difficult in trauma patients. Sometimes it's not because they're young, they have big, vessels, but oftentimes they're hypotensive, they're in shock, they're shunting their blood to their torso, and getting access is hard. Maybe they're altered, maybe they're fighting us. So it's a job to get IV access. The average pre-hospital IV increases scene time by 5 minutes. And 5 minutes doesn't seem like a lot, but it can make a difference in a critically ill or injured patient. For short transport times to trauma centers, current data shows that rapid transport is more beneficial than IV access. And so it's not to say that we shouldn't be starting IVs on patients, but that we shouldn't be delaying transport to establish a peripheral IV. It should be done on the road. And when it's tough, studies have shown that medical providers are slow to initiate IO access and often do so only after multiple failed attempts at IV access. Why? Patients are critically ill and we're messing with a peripheral line that we may or may not be able to get. Put an IO in place, get things started, do it on the road, and get the patient to the trauma center. I think that alone can help us to turn these numbers around. What else can we do? We can Administer IV fluids with caution. Well, why do I say that? That doesn't seem like what our protocols are all about. Well, what we found is that crystalloid infusion directly correlates with increased incidence of coagulopathy. And that coagulopathy is associated with a 5-fold increase in mortality of trauma patients with shock. So IV fluids can be helpful in a patient who's profoundly hypotensive following a severe traumatic injury. They can be life-saving for sure. But if the patient's not hypotensive, maybe we don't need to be rolling in a bolus of fluids. Maybe by doing that, we're making the patient worse. That may be one of the things that's contributing to those numbers that we looked at earlier. Fluid resuscitation and hemorrhagic shock induces moderate and sometimes severe hypothermia, inhibiting the clotting cascade. If we are running in fluids, running in warm fluids is much better than running in cold fluids. Running in cold fluids just makes it harder and harder for the patient to clot. And targeted fluid boluses should be reserved for patients with hypotension or other signs of decreased peripheral perfusion. So again, using IV fluids judiciously instead of just running them in with every trauma patient. How else can we improve as a system? Well, less invasive airway management. Intubation at the scene delays transport, and failed attempts may worsen the patient's airway. RSI inhibits the patient's sympathetic response and can induce cardiac arrest in multi-system trauma patients. And I've seen this in the emergency department. The patient is sick, we RSI them, and they arrest. And I've seen that over and over and over again. And sometimes it's unavoidable. If the patient has a GCS less than 8, then you got to take their airway. But maybe you secure their airway with a supraglottic airway device or something other than intubation and RSI. It's just something to think about. Positive pressure ventilation increases intrathoracic pressure and inhibits venous return, right? As you're pushing air into the chest cavity, you're increasing the pressure within the chest. And by increasing the pressure within the chest, it makes it harder for the body to push blood back to the heart by way of the venous system. And its positive pressure ventilation is associated with hypotension. So we can make a patient who's already unstable more hypotensive by RSIing them and putting them on a ventilator or bagging them. BLS airway adjuncts or supraglottic airways should be the mainstay of EMS airway management, especially in terms of getting these patients, these critically ill patients, to the trauma center as quickly as possible. The one thing that really makes a big difference in patient mortality is getting them to the trauma center. And that's where our strength lies. That's where our tools will help us. And these other things can be done en route, but not having prolonged scene times as we do all of these other treatments. What else? Fewer needle chest decompressions. So a needle chest decompression or a thoracentesis should really, remember, only be done for an unstable patient with signs and symptoms of a tension pneumothorax, not just a regular pneumothorax, but a tension pneumothorax. And the prevalence of pre-hospital tension pneumothorax, we know, is very low. From studies that have looked at this, it's estimated to be about 0.3, as low as 0.3% of these patients. And so in most cases, putting darting the chest is not helping the patient. And it's estimated that we'll have to put in about 20 chest decompressions before we decompress one tension pneumothorax. That's a lot of needles in chests that don't need it. Most traumatic pneumothoraces don't even require a chest tube in the emergency department. We see this all the time. Patients come in and they actually have a pneumothorax, but it's small enough that we just watch it, and we don't put a chest tube in. And so knowing that may be helpful. And then Again, there's risks associated with this procedure. So there's a risk of introducing infection. And of course, if the patient doesn't already have a pneumothorax, putting a needle into their chest is a good way to give them one. Primum non nocere. It's, of course, the old adage of first do no harm. And I think that's, always something that's good to remind ourselves, whether you're in the emergency department or in the field. We do a lot of good things, but we can also sort of get in our own way and fail to deliver what the patient truly needs. And in this case, for critically ill patients, we need to get them to the trauma center. So those are our cases that I wanted to discuss. I'd like to just review very briefly what we've learned. One is that I introduced you at the beginning of this talk to a species called Homo sapien. They have a tendency to spontaneously combust and blow up. In some cases, through no fault of their own, they sustain traumatic injuries. And it's our job to try to get them to the hospital to fix their injuries when at all possible. In case one, we talked about a young man who had been assaulted and had a couple distracting injuries, but had that puncture wound to the left axilla that was very subtle. And again, we probably wouldn't have found it if we didn't do a thorough exam and if we didn't look in the right places. And in that case, he ended up with a stab wound to the left ventricle that resulted in cardiac tamponade. And he had circulatory collapse from that and arrested, but luckily was able to be salvaged in the emergency department. In case number two, we talked about a 22-year-old female who sustained a wakeboarding injury, and she felt her knee pop out and then pop back in again. And that was indicative of a traumatic knee dislocation that reduced spontaneously in the field prior to arrival in the emergency department. And we talked about how dangerous that can be from a standpoint of vascular injury and the risk for the patient ending up needing a surgical amputation of that leg if the vascular injury is not discovered and treated within about 8 hours of the time of injury. So again, history is super important here. And if you suspect it, say something to the emergency department staff to put it on their radar. Case number three was a 25-year-old gentleman who was minding his own business using a circular saw when all of a sudden he ended up with a traumatic amputation of a few digits. And we talked quite a bit about the indications, contraindications, and caveats of transporting patients to replantation centers and when to prioritize those patients to trauma centers versus the replantation centers. Case number four, we talked about a 4-year-old male who was pulled from a burning building. He had significant burn injuries, but he also had significant airway compromise and was at risk of dying from asphyxiation related to his airway burns. And we reminded ourselves that getting him to the closest hospital to secure his airway was more important than anything else that we could do for that young patient. In case number five, we talked about mass violence, mass casualty incidents, and how our traditional modes of triage may not be applicable to situations such as this. And we talked about a bunch of strategies that we can employ to be a more progressive system in terms of handling these very challenging incidents. And lastly, for case number six, we talked about a 32-year-old male who was involved in a high-speed MVC and had a lot of really bad injuries. And we talked about the importance of getting that patient to the trauma center as quickly as possible and not prolonging his time at the scene while we did a bunch of treatments that ultimately may not make a difference in his survivability. So those are the cases I wanted to talk about. It's a rough old world out there, and it's easy to find yourself involved in situations where you get banged up and And I wish you all ongoing safety and taking care of patients in the field. What you do is extremely important and much appreciated by your patients and by the EMS agency. Best of luck in taking care of these folks. It's a challenging group, but I think that you all have the skill set to do an amazing job. So with that, I'll go ahead and close the lecture and take any questions that you may have.
Dr. Burley, it's Deborah. If I can, there are a couple questions in the chat.
Yes.
The first one comes from Mary Hudson, who asks, can you please repeat the doing more by doing less article name, year, and authors? Thank you. I don't know if you happen to recall that.
It's from GEMS. I'll go back to it. Oh, there it is. There it is.
All right, thank you. Mary, hopefully you were able to grab that. And then the second question in the chat is from John Lundgren. I'm not totally sure of the context in this one, but it came in during your last set. The question is the reason the quick response time from scene or something else they discovered?
You know, they weren't able to identify exactly and definitively what it was that made patient mortality higher if transported by EMS. But, you know, all things being equal, I think the fairly, you know, the fairly logical deduction from that is that, you know, since we're better trained and we have more toys and you know, this is what we do. I think the logical deduction is that we're just simply we're spending too much time at the scene and not getting those patients to the definitive trauma center to be treated in an expeditious fashion, especially for those patients who are critically injured, hypotensive, shocky. Those are patients to you know, scoop and run and get those patients to the trauma center. And whatever you're going to do for those patients, do it en route. But remember that the most important thing you can do for that patient is to get them to the trauma center quickly.
Great, thank you. Those are the extent of the written questions we had. So if I guess if anybody else has a question, they should be able to unmute themselves and ask the question, or go ahead and type it in the chat section.
Well, while we're waiting for any last minute questions, I'll just remind folks that we're going to send you out a survey that asks you to answer a few brief questions, and that's the way to get your CME credit. So please make sure you fill that out and send that back so that we can give you credit for the CME activity. And then if there are no other questions, I'm happy to answer anything else that may come up later. If you know, something occurs to you, feel free to reach out to us and I'll get you any answers if I can. And once again, thank you all for everything that you do out there. It's continues to be a very challenging environment in which you work, and it's a very imperfect world. And so I think our patients and our population are very lucky to have such great providers going out and safeguarding their lives and welfare. Karina, did you have a question?
Dr. Burley?
Yes.
Dave Jednick. Regarding pediatric burn patients and our current policies for launching helicopters to fly them out, is there any consideration or thought that we should maybe rethink that and look at bringing them to a local hospital first and then having that sent out? Because the extent of the airway, several other things could be identified shortly after transport to a local hospital versus waiting for air transport or logistics on moving them out of county. Thanks.
Yeah, thanks, Dave. Good question. And again, I think it really comes down to, does the patient have an unstable airway or a potentially unstable airway? If they do, they should go to the closest emergency department for airway stabilization. Has the patient sustained significant traumatic injury in addition to their burn injury? If they do, then and their airway is stable, then they should go to the closest pediatric trauma center. In terms of patients with isolated burns where they're clinically stable and it's just an isolated burn injury that's extensive enough to warrant a burn center. Of course, not every burn injury needs to go to the burn center. There's lots of patients who receive burns that are small enough in body surface area or don't involve, the certain areas of the body that would warrant a burn center. And those patients could go to the closest emergency department. Patients with more extensive burns with a stable airway and no concurrent traumatic injuries would be appropriate candidates to go to the burn center. So that's the reason that the protocol is written the way it is. We're like all things, we're always happy to dialogue and look at protocols and see if they need any tweaking, and that's something that we can look at with you if you'd like to dive into that a little further. But that's kind of the way that we have the protocol set up now. Okay, well, thank you, everyone. Once again, thanks for everything you do and have a great one. If you have any other questions, feel free to reach out, and we look forward to seeing you all during upcoming meetings or wherever else our paths cross. So thanks very much, and have a great rest of your afternoon.
Thank you.